Definition: acquired depigmenting disorder, circumscribed depigmented macules patches due to loss of epidermal melanocytes. Leukotrichia, loss of follicular melanocytes. Epidemiology: prevalence 0.5 to 1% worldwide. Age, any age, mean onset 30 years. No proven triggers except Koebner phenomenon, lesions after trauma. Pathogenesis, genetics, family twin studies, 7% of first-degree relatives affected, 23% concordance in monozygotic twins, environment also important. Susceptibility genes, melanogenesis, immune regulation, apoptosis, overlap with other pigmentary autoimmune disorders. Pathogenic pathway 1, genetic susceptibility, melanocyte vulnerability to oxidative stress, impaired WNT signaling, poor repigmentation. 2. Melanocytes release DAMPs, HSP70, HMGB1, activate plasmacytoid dendritic cells, ILCs, IFN-GONG keratinocytes, CXCL910, recruit CD4 plus CD8 T cells, CXCR3 plus, pro-inflammatory cytokines, melanocyte destruction. 3. Resident memory T cells, CD69, CD103, CD49A, recurrence in previously affected skin. Her clinical features: lesion morphology, totally amylonotic, milk chalk white, discrete, round, oval, linear, centrifugal enlargement. Borders convex, early active, ill-defined, hypomelanotic, may have hyperpigmented or blue borders. Sites: hyperpigmented trauma areas, face, periorificial, dorsal hands, elbows, knees, digits, axilla, umbilicus, sacral, inguinal, anogenital. Leukotrichia, 10 to 60%, does not correlate with activity. Koebner phenomenon, vitiligo at trauma sites. Classification 1, localized. Segmental, 1 plus segments, rapid off leukotrichia. Focal, single area, unclassified, may evolve. Mucosal, mucous membranes only. 2, generalized. Vulgaris, scattered patches, acrofacial, distal extremities, face. Universal, near total depigmentation. Variants: follicular, leukotrichia without epidermal depigmentation. Vitiligo punctue, confetti-like small macules. Inflammatory, erythematous margins. Trichrome, quadrichrome, pentachrome, intermediate hypopigmented zones. Hypochromic, phototypes V6, seborrheic distribution. Shed disease course: onset, usually insidious, detected with tanning. Progression, unpredictable, active signs, hypomelanotic confetti lesions. Segmental, stabilizes in 1 to 2 years, generalized, slow or rapid spread. Repigmentation, spontaneous or sun-induced, complete stable repigmentation rare. Scoring systems: VASI, VF, PGA, VSAS, quantify extent activity. Ocular involvement: uveal tract and RPE, melanocyte loss, non-inflammatory depigmented lesions, VKH syndrome, uveitis, meningitis, otic symptoms, vitiligo poliosis. Alessandrini syndrome, unilateral scalp, eyelash, eyebrow whitening, plus facial depigmentation, plus ocular changes. Associated disorders: autoimmune, thyroid disease, plus 15% adults, alopecia areata 2 to 4%, pernicious anemia, T1DM, myasthenia gravis, lupus, Sjogren, RA. Others: psoriasis, atopy, IBD, metabolic syndrome, GVHD. Genetic: APCID-AID, vitiligo via autoreactive T cells. Psychological: depression, anxiety, adjustment disorders. Childhood vitiligo, segmental more common, 15 to 30% than adults, 5 to 10%. Family history, earlier onset, lower incidence of endocrinopathies. Pathology, histology, absent reduced melanocytes, melanA, MART1, MITF, HMB45, diopistane. Differential diagnosis: chemical drug-induced leukoderma, post-inflammatory depigmentation, leukodermas, melanoma, scleroderma, infectious treponematosis, onchocerciasis, tinea versicolor, congenital pebaldism, nevus depigmentosis, halo nevus, corticosteroid-induced hypomelanosis. Treatment goals: stabilize depigmentation, repigment lesions, maintain repigmentation. Topical: corticosteroids, superpotent, high potency, best on face, neck, 6 to 8 week cycles. Side effects: atrophy. TCIs, tacrolimus, pimecrolimus, face, neck, combined with NBUVB Excimer for synergy. Topical JAK inhibitors, ruxolitinib 1.5%, FDA approved, 10% BSA, 12 years. AE, acne, class warning. Phototherapy, NBUVB, first line, 15% BSA, children 6 years to 3 week. Initial dose 200 millios per centimeter squared. Increase 10 to 20% until mild erythema. PUVA, topical, oral, now less preferred. Risk phototoxicity, Koebnerization. Excimer laser lamp, 308 nanometers, segmental or 10% BSA. Systemic therapy: oral corticosteroid mini pulses, dexamethasone 2.5 milligrams, 2 consecutive days, week, 3 to 6 months, halts progression. Other immunomodulators: methotrexate, oral JAK inhibitors, tofacitinib, ruxolitinib, baricitinib, ritlecitinib. Antioxidants, high lipoic acid, polypodium leucotomus, vitamin C may enhance phototherapy. Afamelanotide, high MSH analog stimulates melanogenesis used with NB-UVB, especially phototypes I4V6. Surgical, stable disease 6 to 12 months, techniques punch graft, micrografting, suction blister, cultured, non-cultured melanocyte grafts, hair transplantation for leukotrichia. Combination therapy, NB-UVBs, topical systemic agents, TCI, corticosteroids, JAK inhibitors, antioxidants. Maintenance, tacrolimus 0.1% ointment twice weekly, reduces recurrence, 10% to 40% placebo. Camouflage, depigmentation, micropigmentation, lips, nipples, distal fingers. Depigmentation therapy, MBEH 20% or MMEH 20%. Q-switch lasers, lifelong sun protection required. Psychological support. Address impact on quality of life. Education. Disease nature. Therapy limits. Concealment. Support group.